becoming more interesting and exciting than the lecture, because sometimes lectures are usually provided on the gateway discussions or the more interactions and interest. So let us welcome Dr. Pankaj Gupta. He will be there in our own academic university. You will not be seeing him everywhere, and he is there. Go ahead. Welcome, Dr.
Thank you, sir. Thank you for a kind introduction. Honorable chairpersons, respected dignitaries of Allahabad Medical Association, and esteemed learned audience. A very good morning to all of you. Today, I'll be taking few challenging cases of spine. Actually, starting from the CV junction up to the sacrum, it's a long segment, and covering whole of the segment in a single go is a big task. So I'll be taking the index cases from each and every segment, especially the one which are not simple cases, along with the upgradations and updations of neurosurgery in these eras. Broadly, we classify the disorders of spine in 5 categories. That is congenital anomalies, infective, traumatic, neoplastic, and lastly degenerative disorders. So I will start in chronological order from CV junction and go below up to the sacrum and coccyx. So starting from my first case. So this is the here, that is so this is the first case of atlantoaxial dislocation with basilar imagination. Usually it is a congenital anomaly. It is found in children, but usually it presents in adult age in 30s, 40s, or 20s after some trivial trauma or fall. Patients, they usually present with quadriparesis. What happens in this case that this is cervical junction, and at this place the distance between anterior arc of C1 and the dens is more than the normal. Normally it is less than 3 mm, but in these cases it increases. So the part of dens, it goes behind and starts compressing the spinal cord at cervical junction. That is why it produces quadriparesis. So this is a case of almost 60 years old female, 45 years old female who presented with quadriparesis after a trivial trauma. On examination, she was having spastic quadriparesis, and this is MRI which was showing atlantoaxial dislocation, and the part of dens, it was going above this line. This is called Chamberlain's line, and it is compressing the cord at the CV junction. In this case, the gold standard treatment is C1 C2 fixation. What we do, we put a screw in the C1 and another in the C2, and just like an aesthetic segment, we reduce the abnormal mobility at the C1 and C2. So C1 part comes behind and it gets stuck with the part of dens, and the atlantodental interval it decreases to less than 3 mm. Thus, the posterior part of the cord, that is effective canal diameter, increases. So it results in the release of the compression at the CV junction. So this is C1 screw, the C1 lateral mass screw, and C2 pedicle screw. This area, it is quite dangerous area because you have to go in between the vertebral artery and the spinal cord. So the total corridor over here, it is almost 8 to 10 mm only. So any abnormality or any deviation from your surgical trajectory is catastrophic. It can kill the patient on the table. So you will have to be very precise. Second thing, X-rays don't help. It's all anatomical dissection and insertion of the screws anatomically. We have to dissect this area here. This is the vertebral artery, which is quite in a position with the lateral border of the C1 and C2 joint. And medially, this is the cord. So you cannot go medially, you cannot go laterally. You have to be strictly in the midline. So that is the way. And This area is fully studded with venous plexuses. These venous plexuses, they bleed like hell. So they need very proper tackling. So these are the measurements which we take in case of AD and bacillary imagination. This is atlantodental interval. Preoperatively it was 6.8 mm, but after surgery it became 1.4 mm, which is normal limit. Second thing is the bacillar imagination, that is clivus canal line, it was crossing the tip of dens, it is crossing this clivus canal line. But after surgery, it has come down. So this distance, the posterior uh, effective canal diameter, it increases significantly. This is the pre-op situation of cord and this is the post-op situation. The cord is fully decompressed. There was myelonesia at the cervical junction, but everything went well. This is day 3. This patient was bedridden, and on day 3, she started walking. This surgery is very critical, very crucial, and very complicated, but the results are miraculous. Once you have done it properly, the patient starts walking in 3 to 5 days. And now, after follow up almost 3 years, she's as good as now without any drugs. The second case, same case, atlantoaxial dislocation, but this was fixed type of atlantoaxial dislocation. This is a 20 years old boy who came with quadriparesis after fall. Here, the anterior arch of C1 is fused and the posterior arch of C1 is also fused to the occiput. So there was no mobility on the flexion extension scan. So it is a fixed type of AD. In this case, since the anatomy was quite complicated here, so we went for occiput C2 C3 fixation. Here we put occipital plate and we fix the C2 and C3. Since the C1 is fixed with occiput and C2 is fused below because it is a block segment with the C3. So this construct worked very well and the patient improved. The power preoperatively was almost 2/5 and post-op, this is the picture after almost 1 month. He is walking, talking and doing his normal pursuits. The next case, which is congenital anomaly of CV junction, is Arnold Chiari malformation. In Arnold Chiari malformation, what happens? The part of cerebellar tonsil, this is the cerebellum, this is cerebellar tonsil, it herniates into the foramen magnum and forms a peg-like elongation. Because of this, the foramen magnum becomes overcrowded. It starts compressing the spinal cord, and because of compression on the spinal cord and because of disturbance in the CSF flow and the cervical junction, it develops the serine formation. So there is Arnold Chiari malformation here and the almost cervical dorsal serine formation. She was a 30 years old female who presented with weakness of both upper limbs and dissociative sensation loss. That she was having no sensation for pain and temperature while the sensation was intact. In this case, we went for foramen magnum decompression and we excised the elongated, pen-like elongated part of cerebral tonsil. We decompressed it, opened the fourth ventricle, we ensured the proper CSF circulation, and that was all. This is the post-operative scan after 3 months. The series started resolving, and this was after 6 months, the series is almost gone. And here, the canal diameter is open, CSF flow is adequate, and the CSF intensities on both sides of cord, it is well seen here. So after 6 months, the patient was all right, and there is no problem now. So this is a lady, almost 30 years old female. This is a straightforward case of cervical PIVD, cervical prolapse intervertebral disc. Here, there was a history of fall, and she was having cervical pain with right upper limb radiculopathy, along with right grip weakness. On examination, she was having C5, C6 cervical PIVD, prolapse intervertebral disc, and it was mainly on the right paracentral region. So she was having right-sided symptomatology. The dictum of cervical surgeries and the dorsal surgeries is if you have pathology anteriorly, you have to approach one. If it is posteriorly, you have to go from the posterior. If you try to do the correction of pathology anterior pathology on the posterior side, there are very high chances of deterioration of the power. So we went from the anterior. It is a normal, quite normal, and it is a good procedure. So we went for anterior cervical discectomy and fusion. We used Crowley's gauge in this case. And day 5 patient was discharged. She's absolutely fine. Grip is improved. There is no radicopathy. she's all right. This is a 70 years old male patient who was psychotic, who was quadriplegic, and he was declared as a Pagalati. And he came with this scan. He was not able to move. He was not able to do his normal activities. He was almost bedridden. On examination, he was having spastic, severe spastic quadriceps with flexor spasms. And MRI showed very bad finding. He was having C5 and C6. It was looking like a fractured segment and whole cervical compression myelopathy, severe compression of the cord, buckling of the cord, everything. So two diagnoses was there in our mind. First was cervical compression myelopathy, and second, because of this signal intensity, it was also thought that it could be a tuberculosis triangle. So we went from anterior side with corpectomy of these two levels. So anterior cervical corpectomy, and this is the expandable cage, plate and screw fixation was done. Patient improved very well after 3 months. He is doing his farming job now. He is not on any psychotic drugs and he is active. This young lady, she got road traffic accident and thereafter she developed weakness of both upper limbs and lower limbs. On examination, she got C5 retrolisthesis here and the facet was partially blocked. On MRI, there was a cord contusion at the adjoining area and C5 retrolisthesis was there. Patient was taken for the surgery under general anesthesia. We applied the traction, it got reduced and anterior cervical dissection. The lady recovered very well after almost 3 months. She is having a normal power. Now coming to the degenerative disorders of the old age, the most common is cervical compressive myelopathy. Here we have multiple levels of cervical disc which compresses the cord and it is having myelomalacia. The white signal intensity is white. It is myelomalacia. In this case, you can see at the posterior longitudinal ligament, it was quite thickened and calcified. So we were suspecting it is OPLL, that is ossified posterior longitudinal ligament. This entity OPLL, it is a surgically very challenging task because it is calcified ligament and it is very difficult to cut it through because chances of CSF leakage, chances of cord injury is very high. And since it is a long segment, so it is not amenable for anterior approach. So we went from the posterior approach. We did wide laminectomy and for the maintenance of curvature because it is a kyphotic curvature. Normally we have cervical curvature is not kyphotic, it is reversible. So to correct this kyphosis, we did this lateral mass fixation at the 3 levels and patient did well. She was having grip weakness of the right side and pain and radicopathy. Post-operatively, she improved. Her grip was almost 90%. She improved. Pain was not there, but she developed left-sided shoulder weakness, which is the only physiotherapy now. But otherwise, she is okay. This is another case. The same case, cervical compressive myelopathy. Here there is compression. Here there is compression, and you can see hourglass appearance of the cord. So it is a severe compressive myelopathy. She was having quadriceps, spastic type of quadriceps. Lateral cord dysfunction, cord was severely compromised, and the white signal changes which are visible here is the myelomalacia. In this case also we went from the back because from front you cannot take out 4 or 5 vertebrae. So we went from the back, we did laminectomy, and in this case we tried a new hardware. This is called transfacet screws. These are very recent screws. Recently they have been developed. What we do, we put the screws directly on the facets. The superior and inferior facet. At the right angle of junction of the superior and inferior facet, we insert these transfacet screws. So what happens? During the surgery, you are very able to appreciate loss of mobility and non-mobility at the level of facet joints. So it's a very good aspect. What are the benefits of this screws? Very small hardware. There is no chance of impingement or neck. Third thing, a very sturdy fixation. And fourth thing, it is quite physiological. So it's a very good screw. The only thing is that you need opposing facets. Otherwise, it will not be, you will not be able to do it. Now coming to the dorsal lesion, the most common infective pathology in India is tuberculosis. So this is a D5, D6 level of cord spine. This is epidural abscess. These two vertebrae are They are eaten up, spondylolisthesis is there, and severe cord compression was there. Patient was having paraparesis, power was 3 by 5. We operated this case from the behind, laminectomy, and 2 level up and 2 level below. Fixation was done. In dorsal spine, if we are fixing above D6 level, D6 level is fine. We can use C arms and very well we can put. But above D6 level, the pedicles are very small and very thin. And the diameter of the cord, the canal diameter is also very little. So there is no scope of any mistake in this case. Because if a little bit you have deviated from your surgical trajectory, it will result in paralysis. So in this case, what we do, we put anatomical screws. Anatomical screws, for anatomical screws, we have to excise the inferior facet of the superior vertebra to expose the superior facet of inferior vertebra. Now we take the junction of the superior facet and the transverse process, and that is the entry point. With this LNT, we keep on palpating the pedicle and we negotiate it through. C arms, yes, we can take it for the confirmation, but if we are putting the screws anatomically only, that is the best way of putting screws in upper dorsal spine. One or two word of cautions are there. First thing is, if you cannot fix this dorsal spine, please do not do laminectomy because patient is bound to deteriorate. The only support in this case is from the posterior side. You are taking out the lamina and you are not fixing it. It is going to be a catastrophic event for the patient. So always fix these things. Never rely on weights and postural transfer junctions. They will not help. There is another part spine. This is middle is knee side. This was also fixed and it was because of this patient group. This is the most common L5 external part spine. In this case, the compression on the theta was not that much. The patient was having unrelated pain. She was not able to lie on the bed. So we operated this case, taking out these debris and we fixed it. Now patient is all right. Now coming to the tumors, we'll start from behind and get inside the cord. First, extracellular tumors. This is a very interesting case. This is almost 65 years old female patient. She admitted in general surgery department with colonoscopy. On examination, the consultant noticed that she is having some problem in walking. So they gave a reference to us. Please look into this matter. On another, we found this large tumor. It was extracellular tumor, brightly enhancing, and it was mainly involving the posterior element of the cord. The tumors in spine which involve the posterior element of the cord, they are usually malignant tumors or metastatic tumors. And the pathologies which involve the anterior compartment of the spinal cord, they are usually benign pathologies like the. So, in this case, we operated it, and after opening, there was a huge mass. This is a huge mass. It has eaten up all the posterior elements, no lamina, no spinal process, nothing was there. It was all inferior, and it was a big mass. It was severely bleeding. It was bleeding like hell, and it was having big low voids. So after struggling for almost 2 to 3 hours, we excised it. Decompressed the patient started walking, and the biopsy report was metastatic follicular thyroid carcinoma. Patient was sent for endocrine surgery department of Sanjayani for this thyroidectomy and for radionuclide iodine. Now, this another young man. He was also having this tumor. On the camera, he was looking like an intravenous external tumor. It was looking as if there was a tumor like tumor type of thing. It is present inside the cord, inside the dura, outside the cord substance. So the tumors which are inside the dura but outside the cord substance, we call them intradural external tumors. But on close inspection, we saw fluids here, and one major fluid here, one major fluid here. So in back of our mind, it was there that it could be a vascular pathology. So we kept our case ready. Normally, it was a red dusky mass, and it was having many fluids of big diameters. So we applied multiple clips, 1, 2, 3 clips, and thereafter excised it. This is the dura. It was above the dura, it was external, that was a good thing for us. So we excised it, this was the tumor, and the patient started walking who had come before with paralysis. The biopsy report was cavernous imagery. Now coming to intradural segment, this lady has presented with spastic quadriparesis. On MRI, it was intradural extramedullary mass, which was actually raised as large dural tail was also there. So the diagnosis was meningioma, preoperative meningioma diagnosis was there. So we opened the dura. This is the tumor which was visible from the left side, from the left side, and this was sticking out in the room. Immediately moving, the cord was fully decompressed, and thereafter it was carcinoma meningioma grade 1 and grade 2. Case at the conus region, this young man, he has presented with low backache, radiculopathy, and bladder cord. On MRI, there was a mixed density mass at the conus. This is the conus, and these are caudate vena. It was covered all around from the caudate vena roots. On opening, these are caudate vena roots, bunches of caudate vena roots. So it was dissected well of these caudate vena roots and it was excised in single piece. The biopsy was mucopapillary meningioma, and the patient did very well. Now coming to the intramedullary segment of the spinal cord. This patient was almost 35 years old male who presented with paralysis. Power was done by 5 with bladder wall dysfunction, and he was numb below D4 level. MRI showed a long segment from here up to here. There was a long segment intramedullary mass with series formation up to this junction, up to the junction, and below it was almost no spinal cells. So these are very different cases because you have to enter inside the cord substance, you have to incise the cord substance, and you have to take out. So lots of fibers are handled. Might be they get some damage as well. So we opened the dura, the cord was looking enlarged, and after incising the parameter, and we did midline myelotomy. The cord was incised from the midline. Long segment myelotomy was done, and this is all tumor. We removed the tumor completely, and after complete removal, we applied the file stitches. This is the first visit, and this is the picture after complete file stitches. So, like the cord substance. This is the post scan after 3 months, and this is showing no residue. All the series has gone. These patients, they immediately after surgery, they landed into complete paraplegia. There is no power convergence because if you handle the cord substance in a long segment, especially the dorsal region, it goes into spinal shock. So it takes a long time to come out of this spinal shock if you have not damaged the substance. So it took almost 6 months, and now with the effort of the physio team, he is now walking with this gait on his operation. Another case, he was having low back pain, spastic paralysis, and bladder wall dysfunction. But in this case, the pathology was favorable. This pathology, in previous case, the pathology was epidermal. In this case, the pathology is epidermal. Epidermal tumors, they are very well plane of cleavage, they have very well dissection margins. So without damaging the cord, you can incise the cord and you can take it out very stably. So we did it, and after 15 days, he's walking as we can see. Now coming to the lower down segment, the sacrococcygeal region. Here, tumors are usually large. So this sacrococcygeal tumor is for the male patient who presented with low back pain, lower limb weakness, and bladder wall sensation was lost. All the features of cardiac arrhythmia. So this case we operated with wide excision, and thereafter patient was all right. He was sent to the radiation oncologist. He is all right. This is second case. This is an interesting case because this is a lady. She was a young lady, 35 years old female, and she was her main problem was infertility, secondary infertility. She was not able to conceive for last 5-6 years. After taking many treatments from the gynae department for infertility, ultimately she had been ordered for an MRI, and it showed a large mass here. इसको ऊपर करिए. It showed a large mass here. It was sacrocoaxial teratoma, but it was anteriorly placed. Usually, it is posterior component is also there, but it was absolutely anterior. So first they thought that it is some sort of anterior meningocele, but on MRI it was clear that it is some sort of sacrocoaxial teratoma. So we operated this case as well. She conceived after 6 months of surgery, and this patient was also operated. Biopsy in both cases was teratoma, but the sad story of teratoma is it has tendency to recur. It recurs by default, and we have no definite remedy to prevent it. So next case is spinal hydatitis. This is a very rare case. Hydatitis are common in other parts of the body, in the lungs, in the liver, and other varieties as well, in the muscles as well, in the brain as well. But in the bones and in the spinal cord or vertebral body, it is very rare. The incidence is 0.2% to 1% of all spinal hydatitis. So here there is a big mass. There is a young boy. He is almost 22 years male who presented with polyema syndrome. He is having pain and polyema. So this was the mass. It was validated appearance, cystic and small dotted cysts along with destruction of the bone. So we did wide excision. This is the cord. After excision, the portion which is anterior to the cord, anterior to the sacrum, is also removed, and cord was properly decompressed. These are small cysts which I had preserved for just for demonstration. So after removing all this, he was all right. We used scolicidal agents as well. But again, the sad story in this case is a recurrence. These cases they recur usually. Now coming to the peripheral nerve sheath tumors, this is also interesting case. This is almost 65, 70 years old man. He has presented to the urology department with a renal mass. He was having a right-sided renal mass, big lump in the lumbar region. So after examination, they ordered for ultrasound. Ultrasound showed that it is a renal mass. But thereafter, he was not convinced. He was saying that mass is averting the renal or is coming from the renal capsule. We are not sure. So we went for MRI. This MRI showed that it was a nerve sheath. This is the outpouching, and this is the nerve root. So it was arising from the nerve root. It went into the retroperitoneally, and it has pushed the kidney upside. So it was a big tumor. So along with my onco colleague, Dr. Rajul, we took the classical kidney approach in this case, and this is the last tumor. So we removed it. We took the typical kidney approach. We went retroperitoneally. This is bowel, and from here we took out. This is the psoas muscle. We took out all of the mass, and thereafter the patient became all right. No pain, nothing. He is walking, and he is all right. The biopsy was plain trauma. Now coming to the congenital anomalies of lumbosacral lesion, the most important is split cord malformations. In split cord malformations, we classify this split cord malformation to two types, type 1 and type 2. In type 1, the cord is split with a bony spur. This is a bony spur which arises from the vertebral body, and it splits the cord into two sections, makes the two head cords. When there is bony spur, when there is a bony spur, the two heavy cords, this is one cord, this is another cord. In between, there is a bony spur. When it splits the cord into two, it takes its dura as well. So it's like two dura containing heavy cords are there. So two parts of cord is there. So this is called type 1. And second is type 2. Here only a small fibrous band is found in between the two heavy cords, but the dural capsule is single. So here there is a small fibrous wall is there in between, and it separates the cord into two heavy cords, but the outer covering of dura is single. These are very challenging cases. Should not be done without any proper training, because most of the cases people take out this and they leave it. It is not like that. Split cord malformations are very tedious. In this case, if you will not reconstruct the neural tube, this patient will later on develop retethering of the cord, third cord syndrome, and further worsening of the neurological symptoms once he reaches to the age of 60. Because at that time, cord grows. And if the rod is kept here, then there will be stretching of the cord and it will start having paralysis. And that is possible. So, taking out this mass, reconstruction of the neural tube, removal of this skirt, removal of this skirt is very possible. Another case, failed back syndrome. What is failed back syndrome? Patients who undergo surgery for disc or some instability, after some time they start having the recurrence of the symptoms. So this is called failed back syndrome. The main causes are recurrent disc, the residual disc, instability, like this. In this case, she's a hospital staff of the doctor. She was having pain and instability. It was a very unstable scoliotic deformity. She had been operated by someone else outside. So he just fixed it. So she was all right, and decompression here was also there. She was all right for almost 2 to 3 months. Thereafter, she again started developing severe radiculopathy on the left side. We ordered for an MRI, and what we see, there was adjacent disc disease. Here, the left side of the foramen was compressed at this level. This is compressed. So she was having severe radiculopathy, and examination stress test was popular at 20. So what we do, we redo the surgery. But doing redo surgery in spine cases, previously operated cases, is like a nightmare. Because it's a very small segment, lots of neural structure is there, data is there, whole tissue is plastered, it is adhered, it is very difficult to again open it properly because tissue plates are all lost. So this is my technique. I have almost 5 years to do this. What I do, I don't touch the primary incision. I go paramedian, I take a small incision paramedian under the guidance of CR. We locate this area where we have to go. I take a paramedian incision, and from there, after excising the muscles, I take out the medial facet, 2/3 of the medial facet, and from there, I directly enter inside this space. From there, I take out all this, and the neural foramen is also. So it's a full paid procedure. There is no any other problem. There is no risk of neural tear. There is no risk of neural damage, and your surgery hardly takes 1 hour. So it's a very good procedure. I have 5 cases and almost 1 year follow-up. All the patients are absolutely healthy. So I definitely try to make a series of this case. So usually in conventional cases, we go from here. We remove the lamina, some part of the facet, we do decompression, and we take out those things. But what I do in redo cases, I go from the medial side. I take out the medial 2/3 of this facet joint on one side only, and from here I enter inside this. So that's my way of doing it. Now next is kyphoscoliosis. Kyphoscoliosis, it could be idiopathic, it could be neuromuscular. So this is also a hospital staff. She is having adult idiopathic kyphoscoliosis of long duration, dorsal lumbar. We calculated all the angles, cobs, angle, pelvic tilt, and all that. And thereafter, we operated this patient from D2 up to the L4. We fixed and we did the correction. This is the pre-op curvature and this is the post-op curvature. Almost, I think, 5-6 years have gone. She's absolutely all right. Now coming to the to enumerate MISS techniques, that is minimal energy techniques. L5S1 disc. This was endoscopic procedure. We did endoscopic discectomy. Our mentor, Dr. Amit Singh sir, is always there to help us in these cases because he is master of endoscopic surgery. So we have done this. So it hardly takes 2.5 to 2.75 centimeter of incision. And it's a good procedure, but I think for me, the indication is limited only one-sided, especially left-sided student. This is the best indication for this case. In the rest of the cases, we need very much of expertise. What we do routinely is microscopic discectomy. This is my preference because I have many cases who are very First thing is unique type of disc is extruded, one-sided, two-sided, central disc, paracentral disc, you can do. Second thing, the incision side is hardly 3 centimeter. And third thing is everything is in front of you. If you want to change your mind, you want to go for laminectomy, you want to go from both sides, you want to go above, downwards, you can do it with the same incision. So with microscopic, the results are same, the scale is same, and everything is almost same like microscopic study, but you have got a wider field to give your success. So this is this and the patient style of okay. Now, another analysis technique is spectral techniques with 1 to 1.5 centimeter incisions. Those incisions are given and the spectral screws are placed simultaneously. Patient can be started for 48 hours. This is a very good technique, but the limitations are again limited. It is only done in cases of instability or past practice, but neural function should not be there because neural decompression often is not there. This is balloon kyphoplasty, which is usually done in old age patients, 70, 80s, because of osteoporotic compression fractures. This was almost 86 years old male who was having unrelenting pain and he was having L2 osteoporotic compression fracture. So we went from both sides of the pedicle, put out the balloon, inflated it, restored the height of the medulla, and so it was good. Patient was absolutely all right. He is ready to listen now. This is 16-year-old boy who got a fall from height, and thereafter he was having severe pain, not able to move his limbs, and he was having urinary infection. On X-ray and MRI, it was high-grade disease, so almost grade 3 stasis. So what we did with the rectal fixation and interbody fusion disease, it is engaged. So patient was all right, he started 5 days and he was okay. So what I want to say in this case, in high-grade diseases, the two things are very important. First is interbody fusion is must. If you are not doing interbody fusion, just reducing this segment, it is not going to work. The construct will fail sooner or later. So this is very much important. Second thing, in high-grade diseases, never try to achieve complete reduction. Partial reduction is good enough. It was grade 3 or 4 and now it's grade 1. That is good enough. If I will try to do it, that I will maintain it is in a normal grade, it can cause stretching and further create problems. So never try to overcorrect it. And that actually is always good.